Hello. Good morning. How's everybody doing? Good. I like this room because I can see you as opposed to the other room. I'm Leah Willis. I'm the Deputy Chief of Staff at the ECHO Institute. Some of you I know from previous work at ECHO Colorado, ECHO Utah, and Vanderbilt University Medical Center. So now we have our panelists coming up on stage. Thank you all. So welcome to this panel discussion exploring ECHO's work with the President's Emergency Plan for AIDS Relief, commonly known as PEPFAR. Dr. Bruce Strumminger is our Senior Associate Director of Project ECHO, and he also leads the Global Health Initiatives team at the ECHO Institute, and he'll be moderating this discussion. We're not going to do formal introductions of everyone on the panel, so I just encourage you to take a look on either side of the stage, and you can read through their names and credentials. And at the end of, towards the end of their panel presentation, there will be time for questions. And we just ask that you all use one of the microphones on either side of the room. We have people who can bring the microphone to you, so feel free to raise your hand, and we'll have someone bring a microphone to you. We're recording today, so we'd very much appreciate having all the questions on a microphone. So be thinking of your questions now. With that, I'm going to hand it over to Bruce.
Thank you, Leah, and welcome everyone to our plenary discussion, Transforming Health Workforce Capacity to Bring Global HIV Under Control. In particular, we're going to be focusing on how the U.S. government PEPFAR program, which is the President's Emergency Plan for AIDS Relief, and ECHO have collaborated over the last 7 or 8 years to address HIV epidemic control. Just want to give a little background about PEPFAR before we launch in. So as I said, it's the President's Emergency Plan for AIDS Relief. It's the US government's initiative launched in 2003. So this is the 20th anniversary of PEPFAR. It's the 20th anniversary of Project ECHO. So we share a 20-year anniversary. It's the largest commitment by any nation to address a single disease in history. It's already invested $70+ billion. Some of our colleagues will know the exact numbers, but quite a lot of tax dollars in this effort. It's provided care and treatment to millions of people living with HIV in over 50 countries, substantially reduced HIV/AIDS-related deaths, enabled millions of HIV-positive individuals to lead healthier lives. It's really an extraordinary program. I had the privilege of serving as the CDC director in Cote d'Ivoire and then Vietnam between 2007 and 2012. Most of my work focused on PEPFAR-related work. And then at ECHO, I've had the privilege to help as an implementer. But as we navigate the multifaceted landscape of global health challenges, our focus today turns to the profound implications of the ECHO case-based virtual community of practice learning model in strengthening the worldwide response to HIV, significantly bolstered by the support from PEPFAR, financial support. Not just financial support, but also intellectual support, and support in many ways that go beyond money. We're privileged today to be joined by esteemed representatives from a number of our partner organizations. This includes Leonard Bikanezi, who is with the Ministry of Health in Namibia and is the Chief Clinical Mentor for HIV there. Martin Ndafuna, who is the Country Director for JPIGO Uganda. Janelle Wright, maybe raise your hands as I call out your name, who's with the US Centers for Disease Control in Central America, worked with me when I was in Vietnam, so it's super fun to have her here. Upasna Agarwal with the National Institute of TB and Respiratory Diseases in New Delhi, India, and Steve Wiersma with the US Department of Defense Health Agency HIV program based in Lusaka, Zambia, leading the Department of Defense military medicine HIV programs for Africa. So this panel will be sharing their insights in implementing programs in a wide variety of different geographic contexts. Just before we start, I want to say that PEPFAR has been a catalytic investor in ECHO programs in Africa. Colleagues at the CDC using PEPFAR funding supported the first ECHO in Africa, which was in Namibia. And from there, I think at least 40 or 50 ECHO programs are now supported across the world, in Asia, Latin America, et cetera. Also, ECHO has become really an important learning and workforce development tool for PEPFAR. In some cases, Steve will talk about how, for the Department of Defense programs, it's really become a strategic initiative for them. In other agencies like USAID and CDC and HRSA, they've supported multiple programs. They haven't necessarily moved to a strategic partnership, but have supported many programs. Also, as we're going to hear, there have been significant ripple effects of the PEPFAR investments in HIV-related ECHO programs that have helped to develop basic ECHO infrastructure in many countries that other health programs have leveraged. And during COVID, those HIV programs were often leveraged to help address COVID, the COVID response. So to begin our session, I'm going to ask each of our panelists to spend about 3 minutes giving a basic overview of the work in your country, the burden of HIV, and the goals of the ECHO programs that you helped to design and implement. And I'm going to start with Leonard Bicanesi because that was the first ECHO program supported by PEPFAR. Leonard.
Thanks, Bruce. So maybe let me start by just briefly talking about Namibia so that people appreciate the country Namibia. So Namibia is one of the countries with the least population density. If you're comparing it with the state of New Mexico is about, it will be 2.5 times. So Namibia is 2.5 times bigger than New Mexico with a population of just around 2.6 million. So what it means is our challenge outside having not a lot of experts in HIV, the other problem is the distances that patients have to travel to seek or to access to care. When it comes to HIV, currently it sits about just around 280,000 patients living with HIV in Namibia. The Project ECHO Can Treatment program in Namibia started in 2015, and it started with just 10 spoke sites as a pilot program. And being in Africa is the first country, a number of things had to be adapted to in the context of Africa. For example, not all of the experts were the hub, some were the spokes as well. We had to navigate around the internet challenges as well. So the CAN treatment program has been running since 2015, every Tuesdays at 3 p.m. Central Africa time. In fact, one was just held this morning, and I had an opportunity to just log into that site, that session as well. Currently, we have 57 sites now, and that includes 5 of them in correctional facilities. And we also have an HIV drug resistance in addition, which runs every Wednesday. Our participants includes doctors, nurses, pharmacists, and some of the community-based practitioners as well. Among a few highlights of our program over the last close to 8 years is in terms of how we've standardized HIV care, how we've decentralized care as well, in terms of making sure that it's available in all clinics, and also how we maintained HIV services during COVID-19. Currently, Namibia has got 95% of their patients know their HIV status, 97% are on treatment, and the viral load suppression is at 94%.
Thank you, Leonard, for laying the groundwork there. Martin, share the Uganda experience with us.
Thank you, Bruce. Good morning, ladies and gentlemen. Uganda is in East Africa, with a population of about 47 million. We have about 1.5 million persons living with HIV. And when the journey around JPIGO getting involved in the response really started, the issues were around the 95 goals, which were really not performing very well, especially the last 95. And the second one, really. And so that's when CDC and HSA really looked at leveraging this tool of ECHO to make sure that we improve on the bits and pieces. And one of the areas which was identified was capacity building for our health workers. And so really, by and large, what happened, if you look at Uganda, the doctor-patient ratio as of 2020 is about 1 to 25,000. There are very many clinics which are run by lower cadres in terms of health facilities, nurses, and sometimes even lay volunteers. You find that sometimes the turnaround for the results was really taking so long. So ECHO was meant to be addressing a bit of these issues. So around 2019, 2020, we got started in this journey with the drug resistance ECHO. Now that drug resistance ECHO was led by the ministry with a steering committee from the ministry. And since then, it used to run once a month, once a week. But as the numbers grew, we were hitting 200 people. But our capacity building was to help that frontline health worker have the tools to be able to speak, to be able to respond to the patient. So we broke it up, made sure that we devolve it further to the regions, and made sure that regions now would be able to see the patients instead from national level. And therefore, the backlog which was there, we have about 14 regions. So the backlog which was there really was taken away because now each region was seeing their patients and discussing with the support of the central hub at the center. And that has quickly turned around the backlog to some point where now we are looking for cases in some of these regions. We literally have to call sites and say, do you have a case to present? Because by and large, that has happened. It has greatly, if I may say some of the impact, it has really improved the competence of some of these health workers. I told you that some were nurses and midwives who waited for a doctor to make the switch decision. Today, they make the decision and they follow up the patients going forward. Thanks.
Thank you, Martin. Janelle actually was helped start one of the first PEPFAR-supported ECHO programs when she was in Kazakhstan in Central Asia, and then actually wrote her PhD thesis on the evaluation of that HIV ECHO program, and then moved to Guatemala to lead the HIV and TB programs for CDC in Central America. Janelle.
Does anybody know where Kazakhstan is?
Raise your hand if you know where Kazakhstan is.
Oh, you do?
Excellent.
Okay. Fun fact, it is the 9th largest country in the entire world by landmass. So I don't actually know the comparison to New Mexico, but that was a really good fact. I should know that. I will figure that out and let you guys know. When I was in Kazakhstan, I covered all of Central America, which is larger than just Kazakhstan. It covers 75 million people. And so the burden of disease in Central Asia is actually fairly small for HIV, but it's very high among key populations. And when I say key populations, this was mostly PWID, which is a fancy term that PEPFAR uses for people who inject drugs. And this is a population, as you can probably imagine, that the government is not super keen on providing support for. And so through the support for PEPFAR, we worked with the ministries of health, we worked with the clinics, and the postgraduate institutes to develop a Project ECHO to support the clinicians and each of the AIDS centers that were providing support for people who inject drugs. So this was, and other people living with HIV. So this was a huge effort because it also covered issues around methadone treatment, needle exchange treatment, or initiatives, and then other, consolidating on treatment. I think that there were over 50 schemes of treatment at the time that we started Project ECHO, and we consolidated it into 3 or 4 schemes for treatment for HIV, and we were able to disseminate a lot of that information through the Project ECHO network. Then I moved to Guatemala, and I cover all of Central America. So does anyone know where Guatemala is? A lot more people. In Guatemala, and so in Central America, we cover everything from Guatemala all the way down to Panama. and in Colombia and Peru. And so through the Project ECHOs in Central America, we started them as country-based Project ECHOs, and then because of COVID, we consolidated them into a regional Project ECHO, and through a series of evaluations, we were able to determine that while people were very, very excited and happy to participate in the Project ECHOs, we had over 200, 300 participants, and we were unable to actually create a community of practice, which we found is to be one of the key components of Project ECHO. So as of this fall, we're going to be decentralizing to the different countries and promoting and starting new Project ECHOs in each of the countries, led by the regional ministries of health, and I don't see any of them here, but they're our implementing partner, and that's been a key partner in launching the Project ECHOs.
Thank you, Janelle. Upasna?
Yeah, hi. Thank you, Dr. Bruce, for this opportunity. So India has about 2.5, I'm sorry for my voice, I took inhalers in the morning. So India has about 2.5 million people living with HIV, out of which about 1 million are women and about 70,000 are children. If you look at the new infections, new HIV infections annually, there are about 70,000 new infections annually. And the latest estimate that we had in 2021, it showed that we went down by new infections by nearly 46%. And we also went down by AIDS-related deaths by 75%. But there was a big but. But when it came to HIV-TB co-infection, the mortality was still unacceptably high. Like nearly 30% of the people who had HIV and TB were dying, which is ridiculously high when you think of it that people without HIV in India, the mortality rate is only less than 5%, about 4%. So we are not talking about complicated MDR-TB cases, we're talking about the regular drug-sensitive TB. So a decision was taken at the higher level that a lot of people get lost going from the national HIV program to the national TB program. An HIV person is first referred to the TB program for diagnosis, and the TB program has to take over. So it was decided that now both HIV treatment and TB treatment will be given through ART centers or the state-run government clinics. So now what happened, people who had been extensively trained in HIV medicine had also to learn about the TB guidelines of the country. And this was somewhere in 2016 and 17. It was a very difficult time, and actually, I'm sorry to say, but it was worse for some time, because we had stopped referring the patients to DOT centers or the TB program while we were yet not ready. The HIV clinics were yet not ready with the TB diagnosis and treatment. So considering this problem, so identifying this problem, we decided to start a niche clinic of HIV-TB, in which we only talk about HIV co-infected TB patients. This clinic started in 2018. It's been 5 years since we have started it, and we cover about 180 HIV clinics in this center. So once this thing was decided that, okay, we want a HIV-TB clinic, and we got permissions from the Central TB Division and the National AIDS Control Division. So like there were two ministries from whom we had to take permission. We needed logistic partners, and that's when CDC stepped in with their PEPFAR fund, and they gave us logistic support to run this clinic.
Thank you, Upasna. And Steve?
Yeah, good morning, everyone. I work for DoD HIV/AIDS prevention program. We're one of the minor partners in this PEPFAR endeavor. So the giants have spoken. They're USAID and CDC, and there's Peace Corps, and there's DoD. So we are based in San Diego, California. We're an entity of the large U.S. Department of Defense, but our work is exclusively with foreign military medical departments around the world. And we work in 45 countries with PEPFAR and non-PEPFAR funds. And it's because these medical facilities often get overlooked by ministries of health. Unlike in the US and Western countries, these health facilities provide care for mostly civilians. It's usually 80 or 90% of their clientele are civilians, and so they also need our support. So we learned early on about Project ECHO through one of our implementing partners that had a lab ECHO working in multiple countries. And we thought this is a really good model. It really appealed to me because I had been in the Air Force and I had been in a windblown tent living out in a distant place where I had no one to talk to about difficult cases. And I said, no, this is what we need around our programs. So in 2020, we started right at the beginning of the COVID pandemic, and we were envisioning a kind of a central model with our hub in San Diego and spokes going out to these countries. We soon realized that was not the approach we wanted to take. We wanted a decentralized approach, and we were going to work in all these 45 countries. So then we heard about being a super hub, and we have now become a super hub. We've been able to start echoes in 12 countries, so that's about a quarter of our goal. We want to go to all these 45 countries. By the end of this year, we'll be about a third of the way through this. And so we think we've got a good start. The impact is what we're trying to measure now, and so we're spending a lot of our time on evaluation. We're also trying to move in some other areas besides HIV, TB, because we know the needs are great, and these military medical systems are very small. But they're all very interested in this model and have embraced it very warmly.
Thank you, Steve, and thanks all for those introductory remarks. One thing I want to remind the audience is we are hoping to have about 10 minutes for Q&A from you. So please think of questions you might want to ask our panelists, and we'll give you an opportunity to dialogue with us. But I want to ask Leonard, it's been 8 years since Namibia started its HIV ECHO program. How's the Ministry of Health in Namibia, what has sustainability looked like? How has the ministry engaged this work, and what's the path for sustainability been like there?
Yeah, thank you. I think it's a question that most people are asking, especially in terms of PEPFAR-supported programs. What is the sustainability part of it, especially in Africa? So when the program was started in 2015, it was led by different implementing partners. But over the years, there was a gradual shift to the program being ministry-led. So things were moving in terms of human resources. The coordinators of the program, initially they were under the implementing partner, but over the last years, that has been taken care of by the ministry. And also in terms of the actual logistics, in terms of expansion, where to expand to, the kind of equipment that is required, the ministry now is taking the lead in doing so. So as we speak now, everything is under the ministry. Of course, we are still getting support. I mean, the funding is still coming from CDC, but it's ministry-led in terms of the coordinator, the director, as well as the IT team. So that has really helped to sustain the program. Not only that, the internet connectivity has also gradually been shifted to the ministry's account. So some of our sites, almost 50% of them, are now fully funded and supported by the ministry. The goal is to ensure that eventually, in a few years' time, everything is actually ministry-led and financed as well. So I think that has been the pathway, and that's my vision, to ensure that ultimately we can prove to people that what can be studied through funding can actually be taken over by the respective ministries. In terms of the program itself, I think I'll just highlight one thing. I think making it relevant. Over the last almost 8 years now, it can be easily become a routine. But we've ensured that the program remains relevant. The knowledge we are sharing is also appropriate and given at the right time. One of the things that we've done is called data-driven didactics. We have a team of clinical mentors, and as they see the number of gaps that are being spoken of, or the clinical cases that are being presented, or challenges, those form our didactic topics in the next coming presentations.
Great, thank you, Leonard. Martin, I wanted to ask you, how has the transition from in-person training that was the norm to digital and electronic training using a program like ECHO, how was that experience in that transition? What were the I know there were some challenges with that. Maybe you can share them.
Thank you very much. I think at the beginning we were called the Zoom experts. At that point we were just teaching people how to find their mics and turn off the mics and like just make sure that there is order. But really quickly we realized that the health workers also needed the skills to use the digital kind of platforms. So that is something that really, the transition was really very good. The other thing was around content. Like you can't just bring the other content and just put it in the digital space where you are doing low dose, high frequency. So that was something which was also tweaked in a way to make sure that we have those 1 hour sessions or 2 hour sessions, but they're full of action and taken forward. I must say that right now, I would say, first of all, even the whole COVID response in Uganda was piggybacked on what the ECHO platform really started. And I remember when we started it around early 2020, I went to some people in the ministry and they said, Martin, that happens in the Western world, not in Uganda. So they were thinking the virtual things are for, but today I'm telling you, they're the ones who are calling us, Martin, JPIGO, we need this support, we need this support. So the transition has happened, and I think when I listen to some people who are doing evaluation, I would like to interest PEPFAR in some of those big meetings which we used to hold in Kampala, and a whole room like this would be full of just PEPFAR delegates and IPs. It no longer happens. They just send a link and something like that happens. So the transition has been good, but more importantly, for the health workers, the frontline health workers, right now, they can be wherever they are and be able to share a case and get a solution and respond to a patient who really is in dire need of help.
It sounds like in Uganda what you're saying is many of the healthcare workers, and I think there are over 300 plus healthcare facilities, that 300 or 500 that participate, that it's become normal. But in 2020 or 2019 when you were starting, my memory was you were having a lot of challenge getting interest from senior Ministry of Health officials in virtual training.
Exactly.
And I'm curious, was that about people not being able to collect per diems by going to in-person trainings? Was it more that, or was it more they just thought it was too far out, too first world an experience to imagine, and that when you said, oh, that's something that happens somewhere else, which of those did they see as the hurdle to embracing this type of training?
Thank you. I think the very immediate threat was the removal of the per diem. Mm-hmm. But quickly, some of these health workers, especially frontline health workers, had patients to deal with and no doctor in sight. And so when we quickly pivoted and across all USG agencies, sharing with their implementing partners, they came on board. But initially, they felt, actually, they used to say, you, JPIGO, together with PEPFAR, you are the people who are responsible for taking away our per diem. But we said, you see, the pandemic is right here, and we cannot be meeting. But eventually, actually, I usually tell people the pandemic was also a blessing in disguise because it really drove the whole process, and the adoption really was that fast.
There wasn't a choice of having any in-person training in 2020, so suddenly that was a catalytic event to get people on board.
Exactly.
Janelle, it would be great if you could share, I know you've studied the impact of the HIV ECHO programs in Central Asia and in Central America. What might you want to share about what you've learned about how those programs have had impact?
Sure. In Central Asia, we did an evaluation, a standard evaluation that we've done in many places, looking at participation, satisfaction, learning. And through some qualitative data analysis, we actually did find that there was a community impact when we were able to roll out like I said, the ARV schemes for treating HIV. We were able to determine that there was an increase in viral load suppression in many of the places that, actually throughout the countries, Obviously, that's sort of indirect, but through qualitative data analysis, we were able to talk with the physicians, and they said directly because of Project ECHO and what they learned, they were able to communicate with each other and with the experts in the hub to be able to move forward with those schemes. So in Central Asia, that was our major focus. In Central America, when we've looked at some of the evaluation and the impact, we were looking at our COVID-19 Project ECHOs. So many of our HIV Project ECHO became COVID-19 Project ECHO. And so what we were able to do is look at what was the impact of having a rapid response using our networks, our platform for rolling out a COVID-19 Project ECHO. And through that, we were actually able to see that there was standardized testing and there was less misinformation around vaccines and immunizations and treatment. The clinicians were very interested in clinical treatment of COVID-19 and through case presentations from other countries, we didn't use them from Central America, they were able to actually determine and to see what course of action they needed to take on a weekly basis. So I think the impact was just on the HIV front, we were actually able to leverage a platform for the COVID-19 pandemic as well.
Thanks, Janelle. Upasna, you've been leading your TB ECHO program for HIV clinicians for over 5 years. How has that program changed over the years? How have you changed it to respond to the needs of the doctors and nurses you've been training?
So the first change was that we were initially in 4 states of the country. We have now expanded to 13 states, and we still do a session in English and 1 session in Hindi. Because HIV medicine is about HIV teams, not only HIV doctors. So for the Hindi-speaking states, it's important that the counselor and the lab technician and the community care coordinator understands what we are saying. So we continue to do that in Hindi as well as in English. And now we are covering nearly 180 HIV clinics. The other thing that we have seen in the past 5 years is that in the first 3 years, the initial questions and case presentations were around basic TB guidelines. When do we send the CBNAT? How do we send the CBNAT? Do we wait or do we immediately get an X-ray done? If an X-ray is negative, what do I do? So it was basically about a diagnostic algorithm, about what would be the weight of ATT to give in a patient who's 70 kg or who's 30 kg. So it was basic program stuff that they were asking about in the first 3 years. Even the cases were like that. But for the last 2 years, what we have realized is that as the things have settled down, as the basic problems, the inherent things have settled down, now they're asking more about extrapulmonary TB. Now, almost every session, we have an extrapulmonary TB, and these are really complex cases. I think once the first things first were handled, the extrapulmonary TB emerged, and now our clinic experts are a neurologist, a cardiologist, a spinal surgeon, a thoracic surgeon. So instead of having TB doctors per se, we now have super specialists coming to our clinic for didactics.
Thank you, Upasna. Steve, I know in many of the countries where the Department of Defense works, there are Ministry of Health HIV ECHO programs already running. And sometimes some of the military doctors and nurses have participated in those. Why did you decide you needed to have specific HIV ECHO programs just for the military medicine defense forces?
Very good question, Bruce. Thank you. We benefited a lot from the collaboration, clearly. We learned a lot from these civilian colleagues, but the military got a lot of secrets, right? So we got to have our own, and it's all about community. So military communities are quite tight, and so having our own community was really important to them. I'll just give you one example. We do something really important called peacekeeping operations around the world, and our Uganda ECHO with the Uganda People's Defense Force wanted to be able to support these really important peacekeeping operations. So they'll send soldiers with their own medical support, to countries like Somalia and the Democratic Republic of the Congo. And they were able to build spokes into those countries. I don't know if we've got ECHOs in Somalia, but we have one through Uganda. And that's something the Ministry of Health wouldn't have been able to do. And again, it builds our community and supports the people that we're trying to work with.
Great, thank you, Steve. I know that several of you are working in multiple countries. Leonard, even though you're based with the Ministry of Health in Namibia, you're also a consultant for Project ECHO and have helped mentor other programs in other countries. And one thing that is typical of many of the CDC and USAID and Defense Department personnel overseas is they move around. So Janelle moved from Vietnam, where she worked with me 10 plus years ago, to Kazakhstan, and then to Ukraine to work for USAID, and then to Guatemala. That through, some of you have moved your posting and you have planted new ECHO programs in those places. Others of you, like Leonard, have traveled to, well, your PEPFAR colleagues, like the CDC country director, moved from Namibia to Zambia, and then he asked you to come and help consult on the establishment of that program in Zambia. That PEPFAR has this network around the world, both of US government personnel and of implementing partners who work with them. So through that whole network, it's been a fascinating thing to see how the ECHO programs have spread around the world. So I wonder if maybe, Leonard, you could talk a little about your experience supporting in Zambia, Botswana, other countries, the establishment of these programs.
Yeah, thanks, Bruce. So I think it's really the not reinventing the wheel that has been taking place. I think there's a proof of concept. ECHO does work. I think PEPFAR has demonstrated that very nice and clear. And that's what has been happening. So once Namibia started its first ECHO program, which was successful, the country director moved to Zambia and asked me to come and support Zambia to start their ECHO program. And it happened, and the Zambian program is amazing. It has grown super big, bigger than Namibia, I must say so. And then one of the people I met in Zambia got to become the country director of Nigeria, CDC. And the first thing she did after hearing that she is now the country director of Nigeria was to send me a WhatsApp and says, Leonard, I need you here so that you do the same in Nigeria. And I went to Nigeria and they started a nice, successful HIV program as well. And currently supporting Botswana. My friend is now the country director of Botswana, and he did the same. So there is that proof of concept that ECHO work, and it has been shown in multiple countries. And I think moving forward, what needs to be done is to start moving away from HIV and think about things like non-communicable disease, mental health in people living with HIV, cervical cancer screening, because the resources are already laid down, and what we need to do is to maximize on those things.
So related to that, thank you, Leonard. I want to ask Martin, I know, so you've gone out to different countries to provide mentorship. In other cases, I want to ask Martin, I know a team from Ethiopia, a big team, came and visited your program in Kampala as they were thinking about establishing an HIV ECHO in Ethiopia. They traveled to Uganda to learn from your experience. And can you, which is just wonderful south-to-south collaboration, as it's called, but this peer network that's helped each other.
Thank you very much. A team from Ethiopia, led by CDC Ethiopia. Binyam is around. I know he will be having a session. Please, let's go and attend it. Did come to Kampala, worked with CDC Uganda, brought along the Ministry of Health, and said, how does it work? So also in Uganda, we said, we'll not show them Kampala. We took them far off in Rwenzori, a remote place, and it was a site which was about 40 kilometers from the regional hub which was presenting their case. And so we just wanted to expose them to how ECHO can work that way. good enough, we gave them the link. They also shared with their team in Asmara and Addis Ababa. They all joined the ECHO session. And really, it was learning with really putting your hands on the whole. From there, they've gone back to Addis Ababa, and right now they are running a very brilliant ECHO. So again, to the south-to-south learning that you're talking about.
Thank you, Martin. We have about 8 minutes left and want to make sure we give the audience an opportunity to ask questions. Anyone with a question, we have 2 people with mics who will come to you. Just raise your hand in your question or comment, because a few PEPFAR colleagues are out in the audience, former PEPFAR, current PEPFAR. Yes, and please say who you are and what organization you're with and where you're from.
Hi, I'm Olivia. I'm from Show Me Echo in Columbia, Missouri. I know HIV is often surrounded heavily with stigma and bias, and so I'm interested in if your programs were enough to address that, or if within your programs you had different efforts to see any difference in that particular challenge.
Great question. Who of our panelists might like to address how you've addressed stigma, the issue of stigma through your ECHO program? Leonard?
Yeah. Okay. All right, I'll take that. So I think what we have found out is that stigma is closely linked to lack of knowledge and information. And through ECHO, as information and knowledge was disseminated to the healthcare providers, some of the recipients of our ECHO program are community-based healthcare workers. So they actually interact closely with the community. So as they received accurate information about HIV, how to care for people living with HIV, the different treatment options available for them, stigma naturally also started, decreasing. And one of the things that also helped through ECHO was the decentralization of services and also coming up with what are called community-based ART groups. And that has really helped in terms of reducing stigma as well. As a result, the quality of care that is being offered is almost the same even in those communities which didn't experience a lot of stigma in the first place.
Janelle?
In the 2 Project ECHO, or in 2 regions, one is working, all of them were working with key populations, so marginalized populations. In Central America, it's dealing with a lot of men who have sex with men. And so, like Leonard was saying, a lot of the sessions were focused on providing information for the clinicians around specific and unique services, and also just normalizing the services and making, having experts and high-level clinicians provide support during the ECHO sessions to show that there shouldn't be any stigma or discrimination around these people. And so I think that's been a key part of the Project ECHOs, to be able to get out that information around populations that are generally marginalized or vulnerable, and not so much part of the general population. Thanks for the question, though. It's such an important question around stigma and discrimination.
Thank you, guys. We've got 2 questions I'm seeing. We could get a mic, maybe.
She's got one.
Bruce, I'm Judy Palfrey, and involved with the Gender Equity Initiative here. I'm not so sure about the absolute facts, but I think women are still a very significant population with HIV, and just wondered if you have any particular emphasis now that you're placing on women and their babies.
Thank you, Judy. So I'm going to modify the question a bit. I'd love to both hear, how have you focused on women specifically in your HIV ECHO programs, but also, have you seen that more women have been able to participate in training and education through the ECHO programs than maybe they were previously in the in-person trainings that were offered? I'm curious if you're seeing a more equity of engagement in education activities through the ECHO networks. But maybe Steve, you want to start?
Maybe just a couple comments. in-person training is often not very equitable, right? There's perverse incentives to going to these trainings, and often you get the wrong person there. I think this is much more democratic in terms of who can participate. And we're seeing lower ranks in military systems, and especially voices like women's voices get heard more through this platform. You know, sometimes the big shots show up at the training. You know, we've all seen that. Anyway. But in terms of programming, you know, certainly cervical cancer programs have gotten a lot of attention for our different ECHO platforms, and we're getting ready to launch one on point-of-care ultrasound for obstetrics, which is a really midwife, predominantly women-run women's health program. And this is really exciting because they've got this new technology in their hands, and they're all eager to compare scans of these fetuses, and so that's another example.
Great.
Can I just add to that? Yeah, so genital TB in women is quite a neglected area. So through our ECHO sessions, we have addressed cases of genital TB on several occasions. And I think it has brought the issue of women health to forefront and made them people aware that, okay, there can be something as a genital TB also, which would need extended treatment, need investigation. So that would be my take on that, that genital TB is something that has come up in our extrapulmonary sessions.
Great, thanks, Upasana. Leonard, quick comment?
Yeah, thank you. So, and I think interestingly in terms of HIV, in terms of outcomes, women are doing much, much better than men. So that's the interesting part. So our challenge, like in Namibia and in other African countries, the challenge is actually men. And that's where, you know, all the targeting is being focused on. And then the other part in terms of capacity building now, in terms of gender equity, one of the things that is really prevalent in Africa is things like maternity leaves and you know, issues to do with breastfeeding. So it's not uncommon that if a healthcare provider is maybe breastfeeding or they've just delivered, they're not able to attend in-person meetings or trainings. But ECHO equalizes, removes those barriers. So even if someone is on maternity leave, they're able to access and join the sessions. Even if they're breastfeeding, they're able to do that. And for me, that's really has helped us to reach out to our colleagues, our healthcare providers who are breastfeeding or on maternity leave. Under normal circumstances, in in-person meetings, we would not have had an opportunity to actually train them.
Great. Martin, did you have a comment?
I think another person could ask, I would say even when it comes to the case presentations, previously they were so dominated by the males and what, but as we said, the frontline health workers, the bulk of them, some of them, most of them are ladies, they're the ones presenting some of these cases. So really, like Leonard has said, ECHO has really laid the platform kind of flat.
Thank you. 3 minutes to go. Okay, Alex, go ahead, Alex.
I'm Alexandra Zuber. Thank you for your incredible work. One of the promises of ECHO is that it is a low-cost, sustainable solution, and of course it can be built upon for many conditions, not as you've mentioned, Dr. Wiersma. I wondered if you could talk a little bit about what are your plans for sustainability for your ECHOs. We've heard a little bit, Leonard, you'd shared. How are you planning for that, that ongoing financing for the ECHO? And if you haven't already shared, how has the ECHO maybe been used as a platform for other health conditions? Thanks.
Steve, and I definitely want to hear from Steve and Janelle Bed as representing donors, and then anyone else who wants to comment. Yeah. How are you trying to build that in?
Sustainability, first of all, was the reason we chose our strategic approach to put these hubs in these militaries, not try to run it ourselves, which was our initial thing. Oh, we're going to do this. And so I think that was a really important strategic point. Second thing we're doing is sharing cost data. So just today I was looking at emails. We constantly poll our little network about what it costs to set these up and maintain them and share that data. And so that's been very helpful because some people have this impression that, we can't keep this going. And look at these costs, they're ridiculously small. And so I think comparing that data throughout our little network is good. So we actually have a little MetaECHO. We're not supposed to say MetaECHO because that's branded here, but we had our meeting in Dubai recently, brought our network together to share examples, and And that's another way we can foster these best practices.
Thanks, Steve. Janelle?
I think that Project ECHO has demonstrated that it's probably the most low-cost, widespread training platform available. So it's a really good question, Alex, about that. When we are able to present some of the economic data to the interested parties, let's say, they're very impressed with this. One of the things that I've done in both Central Asia and in Central America is work directly with postgraduate institutes that have the mandate to actually do the Project ECHOs. And so that they can then, have the platform, and they've used it for several other things, especially in Central Asia. And then in Central America, again, we did not use international partners. We went directly to work with the regional ministries of health and a university. A key part of the participation for sustainability is being able to provide some sort of certification or CME. And so these entities are able to provide that, and through that, that becomes part of the institutionalization of their work with, Project ECHO becomes part of the institutionalization of their workforce. I think COVID was, I don't want to say great, but it was helpful in really accelerating that institutionalization. And I would highly recommend, anybody working in that space to work with institutions that have that mandate and that can provide the CMEs.
Great. Martin, you're going to have the last word here. And then
Thank
we're
you
gonna
very,
wrap.
thank you very much. I think the cost data for ECHO has really shown that previously we had meetings of 100 health workers for 2 weeks. Those would go, another 100 would come. Today there is a saving there. And when you talk to CDC, USAID, DOD, HASA, now those savings can be plowed back. So in a way, there is some money on the table. But two, we have also tried to make sure that the ministries of health are in the driver's seat. When it comes to curriculum development, when it comes to thinking of the sessions, they are some of the subject matter experts. So in a way, there is a capacity being built in the teams and being left within there. Three, in countries where we have devolved, it helps because now the regions are running by themselves. For example, in Uganda, 14 regions run every week by themselves. And so we are now just running after them. Did the ECHO happen? Oh, yes, it happened, and the like. So in a way, we started with sustainability in mind. So by involving the ministry, by thinking about a game plan of decentralization, that's a way you can make sure that when you step away, they can now go ahead. Nowadays, we run after them and say, what was interesting? And they say, why did you miss it? So you see, that way you kind of get them interested to keep the train going. Thanks.
Thank you, Martin. I want to thank all our fabulous panelists who are good friends of mine, and it's been super fun to both work with you all and to share the stage with you this afternoon. Also want to thank everyone, all the participants who joined us today. Really appreciate your attention and interest. And before I close, I just want to make an announcement about the Strengthening Health Emergencies Preparedness and Response through Project ECHO work with WHO. The session will be at 2 o'clock in the Kiva Auditorium. Previously, it was in the app as being at 3. It's been changed to 2. So anyone interested in that, please join us. And with that, I want to thank everyone and hope you have a great conference. So thanks to all.
Thank you. Thank you.